adapted some way to what what our aspirations were in a slightly different manner, and we are in the process of some discussions with Shrikanth and their team for how we can adapt this. Ritesh's talk subsequently will give a real-life experience of how that Cachar Cancer Center have used something very similar to what Shrikanth will explain in the first part, and we'll hear from the end user how beneficial it's been, and I really look forward to hearing both of them. So over to you.
Thought I'll give you guys an update on where we are with the EMR initiative, which is obviously our flagship project, but also some of the work that is coming up. But starting with the EMR initiative, I think we have 4 hospitals that are fairly close to starting implementation. So that will be wonderful. I think we were looking forward to actually getting some live work on the ground. And there are 10 others that are already in the process of the vendor selection. And another 5 or 6 that are in the pipeline where we are reviewing their presentation and funding requests. So very good response, I think, across the NCG community. I'm hoping that a lot of others who are yet to sort of make a decision will jump in as well. But more importantly, I think there is a lot of other work that is happening with the empaneled EMR vendors. And I've alluded to that in the past, but we made a lot more progress since that. On the interoperability side, we've identified for the top 5 cancers, 69 clinical indicators that will be transferred from when a patient moves from one setting of care to the other. And work is right now happening in terms of testing it to ensure that that transfer happens seamlessly. All of this is built on the same architecture that ABDM has come up with, so that we can, in effect, advance the work that ABDM is doing, and in many ways show what is possible with cancer care, which we can then apply to other disease conditions. In fact, yesterday, the director of the National Health Authority was in town. So we spent some time with him just to brainstorm that, how do we advance the notion of interoperability of patient records, given some of the challenges on the ground. So they are also very interested to see what we are able to do with our efforts. Second is on the analytics and reporting. We've now have phase 1, which has 13 indicators, and phase 2, which is another 27 indicators. These 40 indicators will effectively form the base analytics and reporting capability that will be standardized across all of the NCGMR products. And hopefully that covers both the clinical as well as management side of the information that people will need. So we'll start publishing those as well as they get finalized. And the entire methodology, how the data should be captured, all of that is being worked through. And then we have 3 subcommittees that were on the clinical side. One was working on radiation, one was working on chemo, and one was working on surgical oncology. All of them have completed their work in terms of detailing out the workflows and the features that will, again, like I said, become part of the NCGMR product. And the vendors currently are doing a gap analysis between what they already have and what they need to develop. So by the time some of these systems get implemented, all of these features will be ready to go. And what we will also do is publish these detailed workflows as a digital public good, as a document that any of you who may not have the NCG EMR but have other EMRs or have a homegrown system can benefit from and incorporate those features, so that longer term, all of us can align in terms of how that data is captured and can be used for research as well. So that's as far as the EMR project is concerned. Some of the other work that is currently in the pipeline, we are looking at telemedicine very strongly in terms of developing a solution that is tailored to oncology, but really focusing on what operating model do we need to put in place that can alleviate the pain point of the doctor, right? Time and again, as when we've spoken about telemedicine, I think everybody generally sort of says, yeah, it's a great solution, it can work. But the problem is it takes too long. We don't have the kind of support that we have in a physical environment. Technology is not the issue, right? We've got a lot of different platforms. In fact, Shrikanth was talking to us about how we can leverage some of the work that they've done. What we are really trying to figure out is what level of triage is necessary, so that when the oncologist, and we know that we are short of that resource, right? When the expert gets on a call, how do they get to the quickest summary possible so that they can have that discussion in a very, very efficient manner. So as again, some of that comes to life, we are doing a pilot initially, but we will roll that out at a national level once we learn what operating model we want to put in place. So that's underway. We are also looking at synoptic reporting for pathology. I think that was the other area that a lot of you had brought up in the survey. We have a very good solution that was developed at Tata Memorial Hospital, and we have now captured some of those requirements. And the idea will be to again find a couple of vendors who can build this and then make it available for all of our NCG members. And then there are a few other things that I will not go into right now. But with that, let me now turn it over to Shrikanth. Shrikanth, if you can quickly introduce yourself and the 10-bed ICU, and then take us through the wonderful work that you've been doing, that'll be great.
How much time do I have?
15 minutes.
Okay, sounds good. So let me share my presentation. Are you able to see this?
Yes.
Okay, wonderful. So I will quickly go through the initial part, and then let's get to the Tele-ICU part. So this project started during the Delta wave of COVID in 2021, April. And as you can see, a big spike happened. We all went through it. And we created this project. Well, this deck comes from my presentation at Sikkim last week, where we launched about 5 hospitals. So that's why you see the logo, Sikkim logo here. So we created a project where we would provide ICU equipment and create basically an ICU, 10-bedded ICU in a government hospital. We would donate this equipment to the government and create an ICU. And secondly, we would deploy this statewide care technology that we had built, an EMR that we had built, which is running on the cloud, so that all the hospitals could be connected. And in each state, we would run a separate instance. The third was the Tele-ICU, which I'm going to talk in more detail today. We'll talk about that shortly. The Tele-ICU basically addresses the acute shortage of medical specialists in the smaller hospitals, the district hospitals and the sub-district hospitals in the government setup. Fourth, of course, is training. I won't get much into training, and the community participation. These are the 5 pillars on which our project has been sort of designed. And moving forward, we provide some 26 pieces of equipment, including ventilators and ABG auto analysis and 5 paramonitors and pumps and X-ray machines, ECG machines, and so on. We actually import our ventilators from Switzerland. We get our ABG from Siemens in Germany, and so on. We've got top of the line equipment, and we deploy these with a 3-year warranty. But today's talk is about Tele-ICU, the hub and spoke model. So soon after we started deploying this in states, we figured out that there's an acute shortage of specialists, especially anesthetists and pulmonologists and so on. So we said, I was actually in Mysore during the lockdown. I met the dean of the Mysore Medical College and the hospital superintendent of the Cachar hospital, and said, would you be open to experimenting with a solution we will build rapidly in order for your specialists at the medical college, at the Cachar hospital facility, to help about 6 or 7 hospitals around in the neighboring area. And that's how this started. And so the idea is to address the acute shortage of specialists. And this is a hub and spoke model, a hub being a medical college or maybe a tertiary hospital, and the spokes being a sub-district hospital or even a district hospital, where we have provided the 10-bed ICU. Later, I'll talk about upgrading legacy ICUs as well. So we launched a cluster in Mysore, where Cachar Hospital was the hub, and these hospitals, Virajpet, HD Kote, Nanjangud, and the others, became spoke hospitals. And we created a bunch of functionality. And so I'll talk a little bit about this. This is important. The first is on the top left, doctor-to-doctor video communication. Okay, during the Delta wave, a lot of people were trying this out fairly successfully in getting doctors to be talking to either the local doctor or maybe even to the patient. But here it is a doctor-to-doctor video communication that's happening. And India has its own, infrastructure issues. Sometimes in the smaller hospitals, we have no power. It suddenly goes away, or the broadband internet goes down. And this is the reality of our situation in the sub-district hospitals and so on. We are in many, many states in the Northeast, and a lot of those very remote areas, bordering Nepal, bordering Myanmar, and so on, their connectivity, their infrastructure is poor. So we actually built this video communication on WhatsApp, so that if all else fails, the nurse can pick up her phone and actually do a video call on our WhatsApp and still connect up with our hub and talk to a doctor. Lower left is the high-res camera. We installed these 5-pounder high-res cameras so that the doctor at the hub, hundreds of kilometers away, could zoom in on the patient. And in fact, with the 24x zoom camera that we have, you can see the pupil dilate of the patient while if you want to really get close up. Of course, on the top right, we see the electronic medical record, which we built. And today it's an open source project, and we have put it out on GitHub, and it's getting a lot of good traction. It has been considered, the United Nations has called it the 50th digital public good. It's being used quite a bit. And the lower right is the 5-para monitor integration. So we actually did a deep HL7 integration with the 5-para monitor so that the time series data, whether it's SpO2 levels or BP and so on, could be plotted for the hub doctor who's hundreds of kilometers away, right? So it runs on the cloud architecture. And you see GCP, the cloud logo there, because they give free access to our states for 1 year. In fact, Azure has also jumped on our program right now. So on the left side, you see the hub. On the right side, you see the spokes. All of these signals are coming through the cloud, which means we can connect the hub. Hub can be anywhere. Even if the doctor's not at the facility, at the medical college, even at home, we have an app, a smartphone app, where they are saving lives late in the night, right? So this is the Mysore Medical College, the KR Hospital hub. And this is our hub room there, where you see the specialist doctors sitting in front of these monitors, TV monitors, helping patients who are far away. And the ratio of specialist to patient, which was 1:10, can go up to 1:50 or even 1:80. Okay, so that's really the gain here, besides the fact that there are very few specialists in the rural areas. So this is one of our 10-bed ICU wards that we have created. You see the cameras on top, and you see our 5-para monitors all connected via LAN and connected over the router to the internet cloud service. So you will see various hospitals, at the hub. You can click on one of the hospitals. You'll see all the patients. If you're a specialist, you'll see the patients. You can pull up a patient record in the EMR. You can basically do a video call with the local doctor. You can see, there are many settings of the camera. It's all preset. Once you pull up the patient, our system knows which is the closest camera. It will zoom in. It'll show the patient. It can zoom into the face. It can show the monitor readings and so on. So that's pretty much it. One thing I will tell you before I stop is there are some new advances in AI that we are doing for smart ICU. Smart ICU is to upgrade legacy ICUs to our standards, as opposed to our own equipment that's there, like the BPL 5-para monitor and so on. We're also building a nurse assistant using a RAG methodology, retrieval augmented generation. We're working with OpenAI, where our standard ICU protocols are loaded into our app, and the nurse can ask in her own language a fairly technical question at an ICU when a patient is crashing, and the AI responds accurately without hallucination. And we have also created a care scribe with AI so that we can eliminate typing for our EMR. So let me stop here. Back to you, Nikesh.
Shrikanth, two things. If you can talk a little bit about what is the current presence of 10-bed ICU, right? Where we've been able to scale, and I think that'll be very helpful. And I know you didn't really talk about your background. I think your journey in terms of what you did with Aadhaar and how you saw this as an opportunity to do something that was really meaningful. I think people will benefit from that as well.
Okay. Well, today we are in 200 plus ICUs we have created in government hospitals. We have raised the funds, we have deployed these and created these ICUs and provided this care software at a state level, at a federated state level instance, and it's in 9 states. We are running about 14 Tele-ICU hubs that connect to these various hospitals. So that's where we are at right now. My background is in technology. I used to, be a chip designer in California and did some internet companies there. Came back in 2002 to work on more social impact projects. Nandan Nilekani and I met up and created something called the E-Governments Foundation. The 10-bed ICU project is a healthcare project of the E-Governments Foundation, which works on governance improvements and so on, where the idea of sort of digital public infrastructure came in, and that led us to the Aadhaar project, I was the CTO of the other project. I created the UID Technology Center here in Bangalore with a fantastic team of the likes of Pramod Verma and Sanjay Jain and Raj Mashruwala and Vivek Raghavan and others who have gone on to do amazing things after that. So my background is in sort of technology, deep technology in Silicon Valley. Then, of course, here in India, working on governance or public goods, digital public goods, if you will. And that sort of is the approach that we have taken here, where every aspect of this system, the 10-bed ICU, is standardized. The reason why we have scaled in 2 years or 2.5 years, if we are in 200 plus cities in 9 states, is because it's the same playbook as other. It's the same playbook as UPI or CoWIN or whatever. So meaning we completely standardize. We use the 80-20 rule. We unabashedly say we cannot solve everybody's problem. So the long tail will not be attempted right now. So those are some of the techniques that have allowed us to rapidly deploy in many, many places to get the most benefit out of such a system. Thanks.
Thank you very much, Shrikanth. Any quick questions for Shrikanth? We still have a couple of minutes before we turn it over to the next speaker. We'll also take questions at the end, but if there are any immediate thoughts from anyone?
Yeah, Lata, go ahead.
Yes, Lata.
Dr. Lata.
Shrikanth, good to see you. Hello, good morning.
Hi, morning.
Hi. So how are these hub and spokes maintained? And how do we know that these ICUs maintain the standards that they were set out to serve? And how is the funding managed for the hubs?
Okay. Okay, there are multiple questions here, but let's look at this issue of standards. There is apathy in the system. There are the HR situation in many of the government hospitals is quite poor. So there is a lot of work to be done to improve this. Again, what we have to do is we have to ensure that they go through training. In fact, I didn't go through some of those slides. The training is not only in the clinical areas. We have a basic life support and an ACLS course for advanced life support training, but we also get into the medical equipment training and the software training. Okay. And I know KCDH is working on some ideas around training in a much more robust way, super important, because today technology is going to play an increasingly large role in, providing for healthcare. So we need to continue to train our staff in the government hospitals, the doctors, the nurses, the attenders, and so on, so that they improve the level of care and patient outcomes. Second, we have standardized ICU protocols. We are working on it. It's not fully done. We have done about halfway through on that. We have about 18 diagnoses, which we want to completely standardize and create posters as well as a book for the nurses to use. These are treatment pathways. In case of an emergency, in spite of the training, sometimes, they need some help, and not all the time they have 7/24 doctor support, and especially a specialist support. It could be septic shock, it could be snake bite, it could be so many different, it could be a cardiac event, STEMI, and so on and so forth. So this is again standardization on the clinical aspect. Unfortunately, I don't have our standard ICU protocol booklet here, but we are trying to ensure that you standardize this, you train them on it, and then give them the ability not only to look at the poster in the book, but also ask the AI. If the nurse says in Tamil that this is a septic shock maybe, but my BP, my patient's BP is dropping, and I don't know what to do, he's crashing, he's going to die, and so on. It gives absolute correct information based on our protocol, not its general knowledge about what it's read and so on. So all of these things we need to do. Of course, lastly but not least, we provide live dashboards of many, many, many parameters. Okay, clinical outcomes is the last thing that comes. Clinical outcomes is the last thing, but before that, is the infrastructure in place? Is the HR in place? Is bed utilization happening? And then you get to clinical outcomes. So all of these have to be done in order to improve the quality of care.
And Shrikanth, you want to answer the CapEx question in terms of where the finance?
Yes. You asked about the hubs, who pays for it. We pay currently, we as in the NGO, we raise the money to pay both for creating the spoke hospitals, 10-bed ICUs, as well as the hub setup. The hub is actually less expensive. It's just some computer stuff and it's some, large monitors and, and so on. And our software, which is absolutely free. The spoke is actually more expensive because we have to get all this medical equipment and ventilators and so on and so forth. But we pay for all of it right now. But interestingly, because of over 200 hospitals and 9 states are live and working, governments are coming and saying, I want to love. Just 3 weeks ago in Victoria, we started a Tele-ICU up in Victoria Hospital. The health minister, Dinesh Gundarao, he said, I want it to go from 40 hospitals that you have donated to 60 more for 100 total hospitals. And we're going to fund this, but we want you to bring all of them to this level of functioning. So I'm seeing more and more governments will come forward and say, I think I'll pay for this. We have enough money, but we need this quality standard. Can you help us implement it?
Hi, can I ask a question? Dr. Deepti from Namakkal.
Yes, Dr. Deepti.
Yeah, as a small thing here, day-to-day basis, we are facing one more thing is medico-legally. So especially with the patients who are in ICU, we have to just document all the things. So how feasible this is and at what level we have taken a clearance that, okay, we should not be in suit that it is medico-legally not a problem to just maintain a remote ICU.
Yeah. No, see, I think I mean, I'm acutely aware of the privacy debate that happened in the country when Aadhaar was being implemented and the P2P laws that have been passed. So in some sense, we have to rely on the new law of the land, which is, I think, a very good measure with respect to privacy. And medico-legal, one of the key aspects hangs on the privacy of the patient that's there and perhaps the workers, the health workers who are there at the facility as well. So my take on it is we have to be super sensitive and careful. That's why the number one thing is our care software is not run by us. We provide the cloud software, but the state runs it on a cloud instance. Of course, we help them technically to set it up and so on, but we have no access to patient data. Okay, that's one part. The other part is, yes, there is a camera in the ward of a small hospital that the specialist is using to ensure that they can look at the patient, they can look at all the details and so on if they need to go to look at the various readings and so on. Now, I have not seen any major problem that people have had because there is a camera out there, because frankly, there is no other way we can deliver care in a critical care setting in a remote area in India where there are hardly any doctors, let alone specialists. So in some sense, you have to see that if the benefits outweigh some of the challenges, we still have to move on. At least the approach that most state governments, all the state governments have taken, there's been no resistance on the fact that there is a camera out there that is helping the specialist to view the patient, if that's what you're referring to.
No, sir, my question is other way.
Yeah.
Other way.
Yeah.
Something happens and then in the court of law, whether we'll be able to just defend that, okay, that this was being monitored remote way. So how to go for that?
Sorry, say that again. Can you repeat that?
More from the medical point of view, Shrikanth, not from a privacy confidentiality point of view that the question is asked. From a medical point of view, what is our legal status of providing what can be considered as medical advice without the doctor being there?
I see. Well, good question. We have had long debates on this. In fact, our doctor-to-doctor communication on our Tele-ICU is exactly to deal with this issue that a doctor sitting 100 kilometers away can't truly take care of the patient and have responsibility over the patient's life. Okay, that was the number one point that came up over and over again in our discussions with the various doctors and administrative staff, that the Department of Health and so on. So we made it very clear, this is not a doctor to patient relationship. This is a doctor to local doctor relationship. There is an MBBS doctor there, sometimes better, maybe a specialist in 1 or 2 areas, but This specialist in the medical college is only talking to the local doctor. The local doctor's job is to take the call. This specialist can only give advice to the local doctor or the nurse, and the local doctor has to take the call as to what to do next. That is the view that we have taken that avoids the medical legal issue for now. But I can see that we are. I think people will push the envelope on this as you go closer and closer. If you're dealing with CHCs and PHCs and health and wellness centers, I see that this model is going to test the medical legal issues.
Shrikanth, there's one question on the chat, and then we'll pass it on. That what will it take to extend the 10-bed ICU to new states that are not yet covered by it?
We are right now, the state of Jharkhand is signing our MOU as of 3 days ago. The state of Kerala is moving forward. There's a whole bunch of states that have come forward. We have about 8 states in the pipeline we're looking at. We also have to, after signing the MOU, we have to raise the money for each state. Our promise is that we will start at least 1 hospital in every district of the state. That's how we get full interest. And we need a chief minister to launch the project. We need a PMU from the state, a project management unit from each state to work with us closely. We have set up a high bar in our MOU, how the states will work with us so that they also deliver and we also deliver on the promises we have made. So we have about 8 states in the pipeline. We're working through it.
Okay, thank you very much, Shrikanth. We'll see if there are any other questions at the end. The only difference or the only point I wanted to draw out is that in Shrikanth's model, the reason they do this at the state level and also partner with the tertiary institute is because that's where the capacity is being created in terms of the doctors, right? So giving all the infrastructure and equipment. The supply of skilled staff, the intensivist, is coming from the central government institute, right? Whichever is the tertiary hospital. Contrasting to that, we'll now let Dr. Ritesh talk about the solution that they've implemented, very similar in construct, but the intensivists are also provided by a commercial organization. So with that, let me introduce Dr. Ritesh from Cachar and hand it over to him to walk us through something that they're already using or have been using for a while. Over to you, Dr. Ritesh. You are on mute.
You're muted.
Yeah, thanks, Nikesh. Good morning, everyone. Thank you for this opportunity. So just to let you know that, can I share my slide?
You want me to share, Dr. Ritesh?
You should be able to share. Are you?
Okay, I'll do that.
And if you can, Dr. Ritesh, also address this medical legal issue as you go along, right? How you've kind of managed that, right? When, in fact, in your ICU, as I remember when I came, there is not even an RMO, right? It's all nurses, and you're connecting with the intensivists in Bangalore.
So just to let you know that, we are a dedicated cancer hospital situated in Barak Valley of southern part of Assam. And to give you a glimpse of the kind of population we treat here, see, this hospital was established in 1996, and this is run by a trust, the Cachar Cancer Hospital Society, which was a conglomeration of local people of Barak Valley, and very few of them were medical people from the medical background. And now this is almost like 27 or 28 years since this hospital was established. And mostly we treat the, below poverty line people, because the industrial support is very limited, and mostly these people are daily wage earners. So almost 90% of the patient will get support either from government insurance scheme or from the hospital. And then we have some NGOs which are supporting the hospital. So from cancer point of view, we are treating all kind of cancers. And when it comes to surgery, like, we have major surgeries in thorax, abdomen, and all these patients would require ICU support. Other than surgical procedures, we have patients who are coming with radiation morbidity, like, pneumonia, or some patients who have chemotherapy related morbidity, like, neutropenia, febrile neutropenia. All these patients would require ICU support. So like in this slide, you can see, the kind of patients which we treat, most of them, they come from either tea garden or agricultural laborers. Many of them are daily wage earner and earn less than 6,000 rupees per month. And many of them have a large family to support for, that they will have 4, 5, 6 members, and only one person who is earning for all of them, and many of the time they take a tough decision not to come to the hospital for treatment, because the cancer treatment is prolonged, like 2, 3, 4 months. Sometimes chemotherapy will take 6 months time. So to take a tough call not to come to the hospital and continue earning for their family. So these are the kind of patients which we see in our hospital. So most of the treatment in our hospital is supported in some or other ways by NGO or government insurance. So this ICU was always a requirement for many years. We did not have a critical care person working for us, and we used to talk to our friends in Mumbai, Chennai, Delhi, or anywhere, and take care of all these ICU patients who require ventilation, who require critical care. And then in 2020 or 21, one of the a friend of our hospital, they suggested us about the concept of remote monitoring. And we approached Cloud Physician. And initially, both me and Dr. Ravi Kannan sir, who is the director of our hospital, we were skeptical, whether this will really work out, because somebody who is sitting far away and without touching the patient, without clinically examining the patient, how they will be able to suggest any treatment for the patient. So we got a lot of reviews from the hospital where they were providing their services, and we thought, okay, let's give it a try, because anyway, we were not having a critical care person. So we started this as a pilot project, and we were really surprised, the kind of services they had. They had a team of critical care person, nutritionist, nurses, microbiologists. So everyone was on board, and they were providing 24/7 services. They had put in a lot of high definition camera in the hospital, in the ICU, and like these are the high definition camera, and they were able to monitor all 15 bed ICU. We have a 15 bedded ICU, so they were able to monitor every patient, what kind of activity they are doing. They were able to see the vitals, like all 5 para vitals in the monitor, and they were able to interact with our nurses, our doctors. Like one issue was there which was raised in the previous discussion about the medical legal issues. So this issue was raised by us also when we had initial meetings with the cloud physicians. And then we decided, that the final call will be taken by the person who is on the ground. If there is a discrepancy in the decision, somebody wants this antibiotic, we want this antibiotic, something like that. So we will be the person who will take the final call. But for many things, that non-surgical problems, like patients who have cardiac issues, patients who have uncontrolled diabetes, uncontrolled hypertension, patient who is on ventilator, their services are, tremendous. Even without us knowing, they will be able to change the setting in the ventilator. They will interact with the nurses. They will see the ABG report. They will see the electrolyte report. If there is an electrolyte imbalance, if the patient has hyponatremia, they will just tell the sisters to go ahead and start the treatment. So initially, we used to have problem because all these nurses who are working in our ICU, they were in a habit of taking the instructions from us on the ground. So for every instruction given by cloud physician, they used to come back to us and confirm, sir, they are telling this, whether we should go ahead and do this. So initially, all these things we faced, but gradually now nurses know, that whatever instructions are coming from their side, if they can go ahead with this, they are generally going ahead. So like, smaller things like hyponatremia, hypocalcemia, change in the ventilator setting, they are just going ahead. If there is any critical decision like change of antibiotic, especially if it is a higher antibiotic which requires a lot of money, they come back to us and ask, sir, they are suggesting some antibiotic which is costing too much, whether we really go ahead and do this. So now we are at a level, where definitely I can say that the quality of ICU care has improved. We have been able to save lot of patients. Actually, I remember 2 or 3 patients. One patient I remember who had a hemicolectomy. She was around 72 or 73 years old, and she had I think hypertension as her comorbid illness, and she developed supraventricular arrhythmia on third or fourth post-op day, and then she collapsed. She had a cardiac arrest. So with the help of cloud physician and with all the medications they suggested, we were able to revive her. We had put her on ventilator, and she was out of ventilator on day 7. She went home and still she is coming and seeing us in the outdoor. So there are 2-3 stories like that. And other than that, whosoever patient is on ventilator, they are able to take care of those patients very properly, appropriately. So the quality of care has certainly improved in our ICU due to the presence of this remote monitoring by a cloud physician. So this is the Google Meet platform where we are interacting with somebody who is on the other side. They have a team of, like I said, doctors, nurses, nutritionists. So, and they are available all the time. One person is there, all the time. So initially, when we started using this remote monitoring, the people from their team, they came, they took classes for all the nurses about how to revive the patient, how to resuscitate the patient, and different other things, how to use the platform, their platform. They have a app, mobile app also, where we can upload all the reports. So all this training was imparted by them initially to start. So their services we started in somewhere in the middle of 2021, and now it's almost like 2.5 years, and it's really good, because we don't have to sit in ICU all the time. We have resident doctors who do the rounds with them. If required, we also go and talk to them. And the other thing is, if there is a morbidity or mortality in ICU, we do the joint morbidity meeting or mortality meeting, to get to the thing, what we could have done to save the patient. Yeah, thank you.
Ritesh, there's a question on the chat. Is support available 24/7 in case of emergencies?
Yeah, so the support is there. Yes. So their services are 24/7. One doctor is always available. If there is a sick patient, we keep talking to them every second or third hourly. But in case of if there is any patient who is facing an acute problem, we always go back and we tell them, okay, the patient is having problem. Sometimes even before we tell them, they would call us, this patient is not good. You please go and check that patient, come back and talk to us.
Any other questions from the group? Okay, great. Thank you very much.
Sorry. I have a question. This is Dr. Madhu Chandra.
Yes, Dr. Madhu, go ahead.
Yeah. So, Dr. Ritesh, this is very interesting. Thank you so much for this wonderful presentation and taking your time out. This must be at a cost.
Yeah. So we are paying them some money around, probably, I think it must be close to 4 or 5, I don't know exactly. But initially we were supported by an organization called as JDC. This is Jewish Development Corporation. So for initial first year, they supported this activity. Now we are on our own.
Okay. So, they don't set up anything like Shrikanth says that they the settings they do, the equipment they provide.
Yes. They provide.
They provide you.
Yes.
Suppose we have or we can reach out to them directly. Ritesh, I would like to get the connect from you if you can, directly mail it to me.
Sure.
So that will be, thank you so much for that. And this is, I think, a wonderful initiative. And probably if you can work on it, I'm sure remote areas like my hospital, we have a small ICU, but yeah, we need 24/7 backup, which I don't have presently.
We knew that we are unlikely to get a critical care person even for next 5 or 10 years.
Same here.
This is coming at a cost, we have, as I said, we have a team of critical care person 24/7, other than the nutritionist, microbiologist, and nurses. So the entire package is in a cost, which is very, very convenient for us.
And do you write down the whatever they say, the nurses write it down? Is it documented?
Yeah, it is
And
documented.
then you take a decision on whether you need to give it or not give it, right?
So now, as I said, many of the decisions the nurses are able to take, that the smaller things like, the changes in the ventilator setting, correction of hyponatremia, hypocalcemia, or if the patient requires an IV, all these things, sisters are able to take the decision. Of course, there is a doctor, all the time who interacts with them. But some decisions like, which involves uh, more expenditure, like, higher antibiotics, they always come back to us and check, and these people, the people who are sitting on the other side, they know our condition, that the kind of patients which we see. So they are always like, they double check, whether you will be able to provide this. Like, initially we did not have a portable ultrasound machine in our ICU. So they would always tell us, that it is better to do the echocardiogram in these situations, but since you don't have, let's try this. So they are always open for suggestions and changing their decisions, based on our requirement or our the facilities available in our hospital.
Thank you, Dr. Ritesh.
Swapna has a question, Dr. Ritesh, that are the conversation between the cloud physician staff and our ground staff, hospital staff, are they recorded? Just again from a medical legal.
I think they are not recording, but they are documenting it, that this is what the discussion happened. And even from our side also, we are recording, if there is a discrepancy, we are recording, okay, this is the decision by CP, this is the decision by our side, and this is what we are doing. But mostly we are, this is just a medical discussion, and mostly we are coming to some common things like, okay, let's do this.
Dr. Lata is asking if the doctor in the ICU is an MBBS person.
I think they are all trained people, like either anesthetist or like the regular critical care person,
And again, I think that is a choice, Dr. Lata, that you can make, right? In many of these lower resource settings, we just don't have the luxury to choose. But the good part is that
they are all trained people, actually.
they're all well trained, and it becomes an upskilling mechanism over time. Also, I wanted to go back, Dr. Madhu, to your question. See, these are the kinds of projects that we, as part of the National Cancer Grid and the Center for Digital Oncology, are considering, that if there are proof points like this where this thing works, right? How do we then figure out a way to finance this for the rest of the NCG ecosystem, even if it's not in full, but a large majority of that money can be raised through CSR funds and other opportunities. And that is really where we want to kind of evaluate some of these solutions and bring them broadly to the ecosystem. Now, the good part is the work that Shrikanth is doing on the public side, that is all similarly financed, right? They are raising the money, they are putting the equipment, and the central government hospital is providing the intensive. So we have a couple of different models, and depending on the situation and the context of where you operate, one of these we should be able to make work. And we'll see sort of how we can expand this to other use cases, within because the infrastructure is there right now. The question is, can we leverage the existing infrastructure, even like 10-bed ICU, to do other things? And we are talking about second opinions or expert consultation, and avoid patients having to travel to the tertiary cancer institutes for certain types of cancers, where those follow-up visits can very easily happen if the right infrastructure and mechanism to upload the documents and arrange the records is available. But no, very, very good questions. And again, thank you, Dr. Ritesh, for walking us through. We'll just open it up for any other comments or questions. We still have about 10 minutes. Yes, Dr. Pinak, you have your hand up. You can go ahead.
Yeah, I'm not doctor actually. I'm from Arunachal Pradesh. I'm with Dr. Gomi Basar. Our question is that is there any specific set of IoT devices to be installed in the say 10-bed facility, or is there any kind of from where the funding would be basically, if it is there? Any specific kind of IoT devices for better care, or rather to say, I just wanted to know how can we remotely monitoring using some sort of devices? Is there is there some sort of device in the market or not?
Okay.
Hello.
Yeah, Shrikanth, I mean, the entire
Voice is
setup is
there.
IoT based in many ways, but yeah, Shrikanth, go ahead.
Yeah. So the
For
device
Dr. Shah,
story.
sister.
Sorry.
Okay, 1 minute. I'll connect.
Okay. So the device story is what I'm
They're asking for Dr. Sun.
I'm
We're
talking.
seeing
Gitu, can you mute
Dr. Hital.
AC?
Yeah.
Yes.
So what I'm seeing on the device side is the device companies are not very good at software. Okay. They do not use HL7 in most cases. They do not use Fire. They have come up with their own serial ports, not even LAN ports, and they are using proprietary ways in which they push data out, if at all you need data. So number one, for our set of devices, we ensured that those vendors, especially the 5-para monitor, since the vitals are so important, that the vendor actually provided us with HL7 through an interface. Even that, our software team had to work with them. And we found it very hard to do that. It took us 6 to 8 months to make sure that worked. Even now, our ventilator is not fully integrated, even though they are committed to do it. So we have another technology. I'll just share with you the screen with AI. We are just testing this out with OpenAI software called GPT-V Vision, where we are now taking pictures of these devices and allowing generative AI to convert this into extracted text through this OCR mechanism that it has. And now we are actually, with JIPMER, we are doing a project where we are trying to take 4 devices. One is the 5-para monitor of other companies. We use BPL, which is fully integrated. But what if it's Dräger? What if it's Philips and so on? So firstly, we're taking the 5-para monitors of other devices. We want to capture the ventilator readings also and extract it like this. We also want the ABG auto analysis printouts, where the nurse using our app, Care app, can take a picture and get it into the EMR automatically, properly in digital form, not as an image. And the same with the syringe pump. These are the 4 devices that the specialists have asked us that they absolutely need. So we're trying to come up with AI methods to get a vendor neutral continuous monitoring going on because of the cameras we have as well as the app we have. IoT is not necessary. That would make it even fewer devices be compliant with an internet connectivity in there. But we are trying to make do with this and improve the existing ICUs that are there. I don't know if I answered your question.
You have answered more than enough. Now, one short question. How about if I could, to store this data in our state data center? Is it possible? Because your software is deployed over the cloud server. Now, is it possible that in our state government have got their separate state data center? Can we deploy your software solution, or the data itself can be parked in our state data center?
Yeah, unfortunately, our state data centers are not keeping up with the times with respect to cloud innovations and so on. So we found it very difficult to do this so-called on-prem deployment in different states with different data center setups. So what we found is, in fact, it is cheaper to deploy it over cloud, of course, with the full compliance of the government of India with respect to data localization, which means it has to run within the country and ensure that each state can run its own cloud instance. To give you a data point of how much it costs for 41 hospitals in Karnataka, we have created 41 10-bed ICUs and 4 Tele-ICU hubs. The monthly cost of running this cloud instance by AWS or by GCP, Google, or by Azure is about 35,000 rupees for the entire state, right? I don't think we can even hire one techie person at that cost, let alone now put infra and people to run it. So my own take is we should use these fantastic public cloud resources that are available, of course, in a very secure manner. That will save us a lot of time and money. That's my experience.
And one question chat, can you guide more on data privacy? I think we already spoke about that. The software company background, I don't know if this is a question more for the cloud physician or doctor. The person who asked the question, can you elaborate? And does India has any compliance like GDPR? I think, like we said, the privacy bill has just been passed, right? So now we do have a PDP bill. But the person who put the question, if you can add a little more color, I think it'll be helpful, from Gujarat Cancer Research Institute. Okay, in the meantime, anybody else before we wrap up?
I think Dr. Pinnock has another question.
No, I think he just had his hand up. I think Dr. Lata is saying that more of a comment, that thinking of this as a long-term solution, maybe NCG should start clarifying the medico-legal status of remote monitoring, emphasizing the fact that care given is similar to care given with an in-house intensivist. Yeah, so we'll follow up on that, Dr. Lata. Obviously, per se, NCG is not in a position to develop policy, but at the same time, we can certainly take care of these kind of issues and bring it up in the right forums to see if we can have more standard guidelines at the central level that allow these things to happen. Just like for telemedicine, right now there's a central paper that provides at least a basic framework. So I think NCG can play the role of being an influencer in that context.
Lata, I don't think we have the regulatory authority to do or influence any of this. My sense would be that this would be a responsibility that's taken up by the individual hospital. I don't think we can expect the hub or the provider to actually take legal responsibility for this. And finally, it's the person on the ground. As Ritesh said very clearly, it's the person on the ground who makes the final decision, and the responsibility does lie with them. But having said that, I think what we are looking at is allowing this chasing the ideal be the enemy of doing what we can given the circumstances. And the alternative to having an expert opinion like this is to have nothing. And therefore, getting this kind of group of experts or an expert in the hub offering advice to the physician on the ground who may or may not be qualified to take those decisions himself is definitely a value addition to the overall quality of care that's provided. But the medical legal responsibility still probably needs to lie with the hospital which is accepting the advice.
So if I can just add on to that, Dr. Pramesh, I mean, we live in difficult times, especially from public perspective. And, even if there is a policy, maybe not a policy decision, but a statement which says that this is acceptable, because sometimes even the person on the ground, the spoke or the hub, they might find it very difficult to defend their choices. I do completely agree that, having someone else given their input helps tremendously. But it might be of help just to have a body say that this is acceptable. So that is, I was thinking more in terms of that.
Dr. Lata, I was just going to add, see, I feel that when online, because of this digital ecosystem we have built, whether it's a tumor board or whether you're getting inputs from other specialists also, I think strengthens the case of the doctor who's attending to a patient locally in being able to say, hey, we got wonderful inputs in case there is a dispute on something that happened, that these were all taken into consideration. This was not a random something that we just tried out as an experiment. So I think it could also have a positive effect that there are many other doctors involved in this.
Okay, fantastic. I think we are almost up for time, but fantastic discussion. I wanted to take the opportunity to thank Shrikanth and Dr. Ritesh for taking the time to walk this group through, and for all of you, obviously.
Dr. Ravi Kannan had a question.
Yes, Dr. Ravi.
Not a question, just that if teleradiology and telepathology and all those teles are gaining ground, in due course of time, Tele-ICUs and other technology-driven solutions will also become acceptable.
Dr. Ravi,
You're not audible, Dr. Ravi.
Cutting in and out, but I think I got the gist of what you were saying, that a lot of these tele things are going to become the future, right? Whether it's tele-ICU or tele-radiology or tele-pathology, and I know he's mentioned that to me a couple of times. So I think some of this will fall in place, right? It may not be all crystal clear today, but I think like Shrikanth was also saying, it if it works for 80%, I think we will find a way, right, to make it happen.
Yeah, just to let you know that we have already started services of telepathology for our diagnostic pathologies, where we know that, this could be the diagnosis. So it's helping us a lot.
And I think the broader concept is that wherever there's a concentration of skilled resources, how do we make the best use of them to support areas where the resources are not as available, and over time create some way of even upskilling and training people. There are many examples where even without a degree, the skill levels are far superior to people who have degrees, right? So all of this is possible. I think we are just looking for more proof points, right, so that we can learn from them and then find a way to scale that across the NCG ecosystem. But once again, thank you everyone for attending on a Saturday morning. This webinar is recorded, so we will upload the recording on the NCG website and send you all a link. The next one I think will be a couple of months out. The calendar, like I said, is also up there. So thank you very much. Have a good weekend, everyone.